fly through the air and just stick to everything and make us sneeze and itch.
Right.
Um,
Well, are you seeing much Omicron there? We're having a resurgence of Omicron.
Here we just went through a big surge. It's backing down a little bit, but for a while it was everybody that had a cold or cold-like symptoms was coming positive for Omicron, and sometimes you had to test the patient 2-3 times to get a positive result, even though you knew basically that's what's going around, and it was probably Omicron. But luckily, not too many people ended up in the hospital from it.
Well, good. Particularly the people that have been vaccinated tend to do better.
Right.
But,
I mean, we do have over like 80% that have 2 of the vaccines.
Oh, that's excellent.
2 shots, yeah.
Right. Well, the slightly troublesome ones are the ones that were first noted in South Africa in February. And they're a sublineage, which is the BA4 and BA5.
Right.
Then it went to Spain, and now it's kind of ripping through Europe. And the somewhat discouraging thing is that the vaccine, it's very elusive. They call it the stealth. This is super stealth, 4 and 5. And I think the people tend to do okay with it, but the vaccine it keeps them out of the hospital or from getting very sick. And so you know about the new vaccine, I guess.
Oh, yeah. Because they're finding that the Omicron is able to elude this vaccine, as you said, and while it's not causing a lot of severe illness, it is causing a lot of loss of work time, school time, and just being a general nuisance to people that get sick with it. So they are proposing the new vaccine that is going to be the original vaccine plus, I guess, for the specific variants of, is it the BA4 and BA5?
Yeah, exactly.
Uh-huh.
So they announced this. They started a while ago, but they have about 350 people in the trial, I think. That's Moderna.
Okay.
And we're thinking that it'll be easier here to get it through CDC.
Uh-huh.
Then how is it getting vaccines approved there?
Usually, once it's approved by the CDC, Panama is already going through its approvals as well, and they usually get approved maybe a month or two, maybe even sooner, after the CDC approves a vaccine.
Oh, that's fantastic.
Yeah, so it's not taking a really long time. They're looking at all the data, and of course, the ones that have the most data are Europe and the United States. And so they base their decisions off of that data, as well as our own local data. But here they're feeling pretty confident that since we have such a large vaccinated population, that they're going to lift the mandatory indoor mask rule on the 11th, I think, the Monday the 11th.
Oh.
So the masks will only be required in hospitals, in clinics, and in public transportation.
Okay. Well, that might help, right? People will be pretty happy. I know that.
People are already celebrating, and I think a lot of people were already pretty much taking their masks off whenever they could indoors and get away with it. So I don't think it'll be a huge change for some people. I think there's a lot of people that are planning on continuing to use their mask despite the lifting of the regulation.
Right. Well, that's okay too.
Yeah, I don't think there's a problem with that. I think if you've got health issues, especially the health minister here pointed out, if you've got problems with immunity, other health issues, you should probably go ahead and keep using your mask for now, because Omicron and COVID is not gone. It's going to be with us forever, but right now when it's spiking, you should definitely protect yourself.
And you are protecting yourself, so that's a personal choice. And I think it's not a bad one. If someone wants to do it, good for them.
Exactly. We don't need to tempt fate for those of the population that require extra precautions to stay well. And it's not a whole lot different than the government mandating mask usage for the entire population. I mean, you might not be as well protected if others around you aren't masking up, but if you know that you're visiting a person that is immunocompromised or has cancer or some other issue that lowers their immunity, then you should think about wearing your mask around that person so that you're protecting them.
Well, sure. And we have an antiviral that I prescribed for the first time this week to an immunocompromised patient.
Right, that's the mixed pill, the combined pill.
Exactly. And here the brand name is Paxlovid, and you take it for 5 days, and it's felt that it makes it, well, it goes away a little faster, takes care of the symptoms.
Now,
but we're not seeing very many very sick people with the Omicron.
Right, it's mostly for the people that are really at risk, correct?
Exactly.
And I do believe we just received Paxlovid here, at least in the public institutions.
Yeah, well, and it doesn't have many side effects. One pill is to cut down the catabolism of the other antiviral.
Okay.
The only contraindication I know is people on blood thinners. If they're on Eliquis and those, they can't get it.
They can't take the antivirals?
Well, they'd have to go off the blood thinner because it'll enhance the blood thinning of the pill that they're taking.
But the only problem with that is that it does take Eliquis and the other, the newer anticoagulants, quite a while to lose their effect.
No, exactly.
So it takes like sometimes a week for the effect to be lowered enough so that you're not at risk when you're taking other medications.
Right.
Would it be then too late to take Paxlovid?
Yeah, it would probably be after a week. But better just to take care of the underlying condition with their blood thinners.
Right, and most of the symptoms of COVID, especially the Omicron variant, can be alleviated with your Tylenol, your ibuprofen, your antihistamines, and your cough syrups.
Oh, sure.
And in some cases, and a lot of people don't know this, there's gastrointestinal symptoms that are associated with COVID.
Right.
You know, the
In
most...
fact, that's one of the, I didn't know that. And looking at the literature, though, it's not unusual at all. It's usually this one seems to be a sore throat and cold symptoms.
Right.
Some people get aches and pains. Some are wiped out for a couple of weeks.
Yeah, lots of fatigue. That's what my patients have mentioned, is a lot of fatigue.
Right.
And sore
We're
throat.
not seeing much of the long haul.
I've seen a couple long haulers, but not too many.
Really?
They mostly describe the fatigue and the body aches and the persistent cough. The cough takes a long time to go away.
Right. So, well, what else is happening with you? What is the majority of patients that you're seeing right now?
Right at this moment, let's see. I'm seeing a lot of prostatitis, a lot of urinary tract, and a lot of upper respiratory, whether it be infections or allergies. Right,
and of course allergies can make the upper respiratory infections a little more easy to catch.
Right.
Do you see many, do you have many kids come in with ear infections, recurrent ear infections, or not so many?
Mostly kids that do a lot of swimming or going to the beach. They're the ones that are coming in with the more recurrent ear infections. I've seen some that you can tell that they've had a lot of ear infections in the past just because their tympanic membrane in their ear is so thickened.
Right. You see the scarring.
Yeah, it's almost like it's a chronic type of issue with some of these kids, and they don't even notice anymore.
Well, right. Well, we see quite a few of them, and the dilemma here is, well, what do you do in a child who has ear infection after ear infection? and we see them because their pediatricians think they might have an immunodeficiency.
Right.
But it, so when would you get concerned? Well, ear infections, if they get more than 3 or 4 in the first 2 years of life, within a year, if they get more than 3 or 4,
Okay.
we worry because of speech development and hearing.
I guess especially the youngest ones that are just learning their vocabulary.
Well, that's the main reason, and we evaluate these kids for immunodeficiency. Sometimes it's almost never immunodeficiency. It could be people that have the lack of one of the antibodies, IgA.
Uh-huh.
So 1 in 800 people here have that.
Okay.
It's usually, I don't know about you, it's usually the internal architecture, the way that the anatomy is in some kids. The eustachian tube isn't equilibrating with outside atmosphere.
Okay.
And they can't drain the ears.
Right, and then the fluid builds up behind the ears and causes the ear infection.
Exactly. Do you see many kids getting tubes there?
I have not. I know that there's quite a few kids that get their tonsils out, their adenoids out, and get the tubes all at the same time. Those are the kids that are usually getting constant ear infections with tonsillitis, as well as having drainage problems from their nose, I guess.
Right. Well, I was recently reading an article about that. They did a study. I've seen some ENT, ear, nose, and throat doctors just take adenoids out, and that would be kids that have sleep apnea, which is surprisingly not unusual in children.
Huh, that's interesting.
Here, tonsillectomy really only obstruction or recurrent strep infections.
Okay.
But the study showed that adenoidectomy did not really do much for recurrent ear infections. So if it was necessary, tubes and adenoidectomy seem to do pretty well.
Okay. Yeah, it sounds like a lot for a child to go through to have all that done.
Actually, it's very, very quick. But, a lot of parents are nervous about half an hour of preparation, anesthesia, and so forth.
Of course. And then the recovery time is pretty quick.
Oh, within a day. Oh, sure.
I do know some adults that have gotten their tonsils out, and they say it's the worst pain they've ever felt in their entire
You
lives.
said it. We have ear, nose, and throat doctors send us adults who they want to take the tonsils out, but the adults are allergic to NSAIDs, to aspirin, ibuprofen. And
Right.
ENTs really dislike taking tonsils out of adults, so it's rare that they do it.
But it does happen, and those adults never forget it, apparently.
No. No, kids sail right through that in my experience. But what we see, of course, is as time goes on, the internal architecture of the eustachian tubes changes. So it's really unusual to have a child, do you see this, less than 5, over 5 that gets ear infection after ear infection?
No, not usually. Well, they're usually kindergarten age around that time when they get the ear infections, and it's usually right around the time they've gotten a cold.
Right. But it gets less and less usually. Most of us just wait it out because by that time they're speaking and good hearing and speech development. It's the early kids, the less than 2, that you worry a little bit about.
Yeah, the ones that won't be able to catch up as easily if they aren't hearing well out of their ears, because ear infections do cause problems hearing. It causes the tympanic membrane not to be able to vibrate against the bones, and that's what helps you with the hearing.
Sure. So we'll see kids who have speech therapy, they might be 4 to 8, and we'll say, well, how did this happen? Oh, he kept having ear infections until he got that fixed, and then
it takes a while for them to catch back up.
I guess it does.
Another thing that I've been seeing a lot of, unusually, is shingles.
Right.
A lot of shingles infection, which, as we know, is a recurrent virus that is related to the chickenpox virus.
Right. So What is the availability of the vaccine there?
I have never seen it, just the chickenpox vaccine, but we don't have the Shingrix here.
Oh, it's very effective.
Right, which is why a lot of people that go to the U.S. to get their Shingrix vaccine, and the only problem is it's a series of 2, if I'm not wrong.
Yes, it is.
So I don't know when the second dose is given, but I believe it has to be pretty.
Within the next several months after the first one.
So
People do get side effects sometimes. You know, they feel sick and so forth. But most people, it's certainly better than getting shingles, which is
I think it's
miserable.
preferable. I've seen shingles in some unusual places, including the groin area. So
Yeah.
that is not a place you want to get shingles.
Well, no, or the eye.
And is it due to an immunological deficit that people are?
No, not usually. And it's not, you know, if you look at the spectrum of ages, people over 50 are more likely to get shingles if they've had chickenpox.
Mm-hmm.
But we see kids with it.
Yep.
And when we see kids with it, I usually do an immune workup, but it's almost always normal. Sometimes they have a T lymphocyte problem, but the vast majority don't, and it's very mysterious.
Yeah, it's not unusual for people under 50 to have shingles here. I've seen quite a few patients under 50 years old that have gotten shingles, and
Oh,
they'd
sure.
really like to get the vaccine, but you can't because you're not old enough to.
Right. Now, how does that happen? Does it get through the Ministry of Health has to approve it?
No, like I said, most of my patients have to go to another country to get their Shingrix vaccines.
Oh, I see.
They were talking about bringing it in here. I'm not sure why they haven't yet.
I see. Well, that'll be great when they get it.
Yeah, definitely. That'll be one of the first on my list after seeing so many infections here.
For sure. For sure.
So
Well.
we were also going to talk a little bit about if there's any new treatments coming out for severe allergies and asthma. I know there's a few types of injectables out to help with the eosinophils and the IgE. They're not readily available here in Panama. What is readily available are allergy shots.
Well, right. So we see a lot of people with asthma that isn't totally controlled, and they're on pretty well everything, which I'm sure is available there in Panama at some expense.
Uh-huh.
But then, yeah, they're the ones that go after eosinophils and so forth, Nucala, Fasenra, Xolair, Dupixent, and they're pretty good in people that have eosinophil problems, whether it's eosinophilic asthma, nasal polyps,
Exactly.
and so forth.
Sinusitis,
The
especially chronic
allergies.
sinusitis due to allergies.
Yes, exactly. So for the allergies, we almost never start people on allergy shots immediately. We usually try the tried and true, and that would be avoidance of the allergen. So if you are allergic to dust mites, and in Panama that's very
You're in trouble.
sure, but you know, do the local things in your house with the mattresses and pillows, the covers, and hot water wash for the sheets and the pillowcases, and if you have blankets over in Boquete.
Yeah, yeah. Definitely
and
have
then-
blankets
and
here.
And then the antihistamines and the nasal sprays. And I think you told me once the nasal sprays are kind of expensive. The
They
nasal
are,
steroids.
but they're like $60 or $80 per
Wow.
unit, so they're not accessible to everyone, the nasal sprays, but the saline sprays are pretty accessible. And although that doesn't bring a whole lot of the inflammation down inside the nose, it does help dry it up some.
It sure does. An alternative that one might think about is most people, if they don't get very sleepy on the antihistamine, like cetirizine or loratadine,
Uh-huh.
and we have patients who just hate the sprays or can't do it because of glaucoma or something like that.
Right.
We just give them the antihistamine morning and night, and it can make a remarkable difference.
Right. I've tried that with a lot of patients, and with some patients, they do pretty well doing that. And other patients, they still are having symptoms, in which case,
Well, they'd be a candidate for possible allergy shots. Then.
right. Right.
And so we test maybe in the 4 offices, probably 20 people a day, and there are
Okay.
people that just aren't getting relief or want shots.
Right.
And we're looking at the common allergens, the pollens of trees and grass and weeds, cats,
Animal
dogs,
dander, yeah.
mold. Yeah. And if the patients want the shots, what's in the shots is what you're allergic to, and which seems like a pretty dumb idea. But they've been around since, actually since the year Panama Canal began construction, 1904, and they're still doing it.
That's a long,
So
long time. I didn't realize the
it's a
allergy
very
shots
long
had been
time.
around for that long.
Yeah. Well, it was an Englishman who discovered that it worked. But in any event, so we do a series of 5 concentrations, and the first is like water, 1 to 100,000 mix. People come in once a week, and each time they get a little more volume. When they get 0.5 cc's, they go to the next vial, which is 10 times stronger.
Right.
And and it tends to work. It takes almost a year to really notice the difference. So we use medicine in the first part of the shots anyway, but it really does work very well.
Yeah, I've
It's
had a few
nuisance.
patients come in that are on the allergy shots. They come in to get their shots weekly,
Right.
and they seem to do really well.
Oh yeah, and it's not forever. What usually is done in most countries is you get up to the maintenance, and then you space it out to monthly if the patient's doing well, for 2 to 3 years, just to keep it from coming back,
Uh-huh.
and that's it, done.
Are there ever any relapses afterwards? Do you ever have to put anybody back on allergy shots again?
Very rarely, but you have to be selective in who you put on. Well, one of the only contraindication that I know of would be if a patient's on a beta blocker,
Okay.
because because it would be a little harder to retrieve from a reaction to the shot itself. If we see people with just a few allergies and they're in the younger age group, we tend to say, no, it's not time yet, because you're probably going to get more allergies. And then you have the dilemma. The allergy shots work for what you put in them.
Right.
They
And only
get-
for those, yeah.
And see, we have some pretty lengthy pollinators here. Oak probably is our worst, and so if they're not allergic to oak, which here pollinates February through May,
Uh-huh.
well then all of a sudden, if it wasn't in the mix, 3 years later they get allergic to oak, because it doesn't stop you from becoming allergic to new things. They'd start having problems in February.
Wow, okay.
But most people here have a fully developed repertoire, even if they're 5 or 6. We never put children less than 5 on.
Right. And it would be pretty
But
difficult to get a child that's even 5 years old to come in every week and get shots.
Right. Although they don't tend to hurt. We use a 25 gauge needle, and they barely notice it.
Right, it's tiny, teeny tiny.
Oh, teeny tiny. Yeah, no one does that. Not in the U.S. and Canada.
Well, I think we got a lot of good information out for people. I know you've got some stuff you need to take care of today, and I would like to thank you very much for being on the program again.
Well, thanks very much. And I was wondering if you'd like to consider specific topics in any part of medicine we could talk about in the future.
I think that would be a good idea, and I'd love to have people write in and suggest some topics that they might want to talk about or hear talked about on the air. And they're welcome to do that on my Facebook page or send me a private message, and I'd be glad to set up specific topics that people want to hear about.
And it can certainly range beyond allergy or immunology or
Oh,
asthma.
definitely. I mean,
Because, as you know, medicine is great fun to practice, and there's so much to impart.
yeah, and we have to know a little bit of everything, because you can't just know your own specialty and not know anything else. Otherwise,
Right. And I know you.
you end up missing something.
Well, I think if you're a good doc, you learn every day yourself too.
Oh,
I
yeah.
sure do.
Always studying.
Yep, we have to keep up.
Well,
All
it's
right.
been very nice
Well-
talking to you. It's always a pleasure to have you on the program.
Well, thanks very much for inviting me.
And we'll set up something in the near future, see if anybody can come up with any good topics that they'd like to hear talked about. And even if they want to call in, that would be a welcome thing for them to call in with their questions.
Well, that would be just fine. Let me just ask this. Is anyone celebrating the 4th of July, any of the Americans there in Boquete? Or...
Oh, yeah, definitely. I'm sure there's a few little parties that are going to happen for 4th of July here.
And how about yesterday, Canada Day? Did many Canadians celebrate?
Yeah, actually, my neighbor made some butter tarts and was passing them out to
Yummy.
a few people. Yeah.
Oh, that's great. All right. Well, thanks very much.
All right. Thank you for being on. We'll talk to you again soon.
It's a pleasure. Thank you.
Bye for now.
Bye.
And my next guest is from the ACCB here in Boquete. Her name is Priscilla Raquel. And she is coming to us on rather short notice today. So I think you're prepared, right?
For the most part, yeah, we've been talking about this a lot. So the last few weeks, kind of getting this all up and running. So
Right. Can you tell me first, what is the ACCB?
So the ACCB stands for Asociación de Caridad de la Comunidad de Boquete. So pretty much it's the charity association for the Boquete community.
Correct.
So recently kind of went through a restructuring of the board, and the new president is the rabbi. And one of the things that was really important to him that he mentioned when he was looking to get elected was, hey, we do all these programs for, the indigenous children or the community.
All the outreach. Yeah.
All the outreach, but we don't do a lot of things for our own community. And so this is kind of where this idea of what we're offering came from, was this thing of, hey, we can't take care of anybody else if we don't have things in place to take care of ourselves.
Now, what is this thing we're talking about?
So what we're talking about, so the idea is we want to try to bring a community first responder group or corps here to Boquete. The idea is for people to be highly trained, about an 8-month training with Fire Panama. They'll have to spend a couple of days in Panama City with ambulance training and everything. And the idea,
so it gets really into
yeah,
that there,
so
yeah.
so it's really, with certification, Mensa certifications, they're going to, as they go through the program, they're going to get different certifications.
Nice.
And the idea is for there to be a hotline, and for when there's an emergency, for there to be someone close by that can attend. Because I think that once I've started kind of doing the market research,
right,
we've heard horror stories of people that really could have survived if it would have been simple CPR, or someone would have known how to stop the bleeding, or something
or
like
someone choking, if they'd known how to do a Heimlich maneuver.
very simple things. And so the idea is we want to try to bring that, and then cut down on some of the ambulance response time, because we know it's not the best.
It's not the best. There's very few ambulances. The one ambulance service, the 911 that's in Dolega, also sometimes has to cover part of David when the ambulance from David is out of service. And out of service meaning its stretcher is in the hospital with the patient and they haven't gotten the stretcher back, that kind of thing.
Yeah, so I think that this is something to where if we have a community that's prepared, because then some emergencies may not even require an ambulance,
Many
maybe
don't.
something. So part of this is what'll happen is people will actually have a kit with a some sort of AED defibrillator.
Right.
They'll be trained on to use it all, and what'll happen is they'll go out in those hopefully first 5 to 7 minutes, and then they'll be able to call the dispatch and say, hey, this really does need an ambulance, or hey, it's taken care of.
Mm-hmm.
So that's kind of where it's all born, of kind of saying, hey, what can we do to kind of help?
And now this is all volunteers.
Yes, so this is all volunteer. So the way that ACCB is playing a part is we're actually have people that have reached out and said, hey, we're going to sponsor people. Also, we're looking to see how we can help pay for the kits, because
Right.
all of this stuff is very pricey. So
Yeah.
so the idea for ACCB is saying, hey, we want to try to make this happen. So there are costs that are involved, but the idea is ACCB wants to definitely do its best to take on some of that responsibility.
Oh, that's excellent.
Yeah.
And so far, what has the response been?
So the response has been pretty cool. Like, I mean, I think there's a lot of people interested because I think, again, this is something to where people are concerned when they're moving here, you know, what happens in an emergency. And
Yeah.
I think that some of the stories that's tied to ACCB, there was a gentleman that passed away and he was a member of ACCB, and had there been something like that, Mark would still be with us. And then on the Rotary side, there was a similar situation that happened with one of their members. And so the idea is this is something to where it's not just ACCB. We're also talking to people from the Rotary, and we're also talking to people from the community, because I think we all kind of have these stories, and it's preventable. So.
Yeah, and it's hard because there are certain places that have an AED, but if you don't use it right away, you know, the person is gone more than a few minutes, you're not going to bring them back.
And then if we talk about how many AEDs we have here in Boquete, we're talking about some
Our clinic has one.
Oh, good. So but then some of it's like locked in Lucero. It's like behind the gated community of Lucero or
Yeah.
gated community of Valle Escondido. So if you don't have access to get in
Yeah.
there. So we're talking about, I mean, it may be in these places where it's inaccessible. So it's almost like not having one as
Yeah.
well. So kind of
And even so, if you're bringing it to the patient or you're bringing the patient to it, you know it's been probably more than 10 minutes, and there's absolutely no...
Yeah, there's no
going
yeah.
back.
Yeah. So this is kind of where this is born. The idea of saying, hey, if we can save a life and prevent something from happening, we want to be a part of that.
Because
So-
people don't realize that they try to bring in their deceased family member, and it usually takes a while to get them in the car, get them to the clinic, and they think that they can bring them in and we're going to try and revive them. But we already know the time for that has passed.
Yeah.
And we just don't do it, and they get upset, like, why aren't you doing it? And it's like, well, you know what?
And we're talking about, you know, how long does it take for someone that's living, you know, somewhere in like Jaramillo or like Alto Kiel to even get to a clinic. And so
Right.
then the idea is saying, hey, if someone's close by and says, hey, there's a call coming in from Alto Kiel, well, they would probably get there a whole lot quicker than that person
Right,
would even
somebody
be able
that's
to get.
already in Alto Cielo or someone that's in Jaramillo.
Yeah, exactly. So
I mean, Jaramillo is way in there sometimes, like especially Jaramillo Centro. And it's a lot of dirt roads, and good luck getting an ambulance to go through there.
Absolutely, absolutely. So I think that the more of the community that we get involved in this, the more successful this will be. And again, this is something that we do for ourselves as well. Like this is not something to where it's like, oh, we're helping the kids in the comarca, which is great. But this is something to where this is going to help, you know, Sam from Ohio, you know,
Yeah.
that lives here. And I think that
And
this
it's
is
not
important.
just expats that are getting involved in this program.
No.
From what I hear, it's a lot of locals that
Yeah,
want
so
to get
there's a
involved
lot
as
of
well.
locals that want to be involved. One of the things that is hurting us a little bit with getting locals involved is the kit.
Right.
So how are these people if they don't have a vehicle, or if the vehicle is their uncle's cousin twice
They're
removed?
not
like,
all that dependable
yeah,
on getting to the...
exactly. So that's been a conversation that we're having, and Yakov has been saying, hey, if there's someone that's reached out and said, well, you know, I do have a vehicle and it may need a little bit of maintenance, and we're looking at all of those things
Yeah.
because we definitely want Panamanians to be involved. It's important to have
Yeah.
Spanish speakers on board as
If
well.
they need a tire or two, maybe you can
Yes,
get a tire donated,
exactly. Because
or-
I think that is something that even
Yeah.
the expat community would say, hey, I want someone living close to me, and if I just need to buy them a tire, then yeah, I'm pitching in for
Yeah,
a tire.
I'll pitch you a tire.
I'll pitch a tire. So, I mean, yeah, so that's what makes this program super interesting. So what we're going to do to start off is we're going to be offering next Sunday, July 10th, the first aid and CPR course. So this is like the introduction course for people. It's a certification course, so people will leave with their certification. The team, Fire Panama team, is coming from Panama to come and train everybody and kind of just get everybody familiar with what this is going to look like. There is a cost involved.
Right.
So it is $120 per
Okay.
person. We have different ways for people to pay. We have our bank accounts. We have a Quanto app that allows people to pay with their credit card if they
Okay.
choose to do so. But the idea is for people to come in and leave with a certification, because even if you know basic CPR and even if you know basic first aid, you're already able to help someone. And so
the basic first aid and CPR course course, that is not like making it obligatory that you become a first responder type of thing. This is just to get as many people certified as want to be certified.
So the idea with this obviously is we would want those that take the first aid course to go on and take the 8-month training, but we do understand that some people are going to be like, oh, no, this is good enough, and that's fine.
And 8 months is a long time to dedicate.
Eight months is a long time. The cool part about the way that they're going to be teaching the course is going to be like a hybrid. So it'll be based on modules online, then it'll have like live videos that people can go back and watch, and then a testing, and then you'll move on. The one thing will require for people to take a couple of days and go to Panama City for the ambulance training, just because it's the quickest way to get people to see different types of trauma and things that they may come in contact
so they go
with.
along ride-alongs and that kind of thing. Okay.
Yeah, so
that's going to be interesting. I mean, that's the same type of thing when I became an EMT that I had to do. You know, I did it through a hospital in Panama City through the U.S. military.
Yeah.
And our course was actually, was it 6 weeks or a month? It was a really intensive course. And we got certified by the National Registry of EMTs.
Wow.
And we did our ride-alongs. We did our time in the emergency room at the hospital, seeing patients and taking vitals and that kind of thing. So we got some pretty good training. It was a lot of fun.
Yeah, and I think I think, again, having people go to Panama City, it's going to be able to for them to see a whole stuff that they're not going to see here. I mean, I think we're not having that many emergencies here, and I'm not sure. You would probably know more than me.
There's actually quite a few that happen. Yeah, there is quite a few that happen. Most of them make it into either our clinic, because we are available for emergencies in the middle of the night, or one of the public clinics.
Okay.
Now, as far as ambulance service, you know, once in a while we'll be able to get the firemen to cooperate or MENSA to cooperate, but usually the family member has to call 911 and request it. You know, if I request it, if it's not a specific thing like this person is actively having a heart attack and needs oxygen, needs whatever to go down to David, I'm probably going to get denied.
Wow.
So
yeah, so that's, I mean, and I think that there's even been talks about, you know, increasing, you know, ambulance services and things like that as well.
There's been talk of private ambulance service coming up.
There's been talk. Yeah, there's been talk. Like, now the thing about it is that, man, it would just be good if we can get the ones that we have to work efficiently. I think it'd be a whole lot cheaper.
I don't know that there's enough ambulances out there to be able to do it, because we can't use the fire ambulance. That is mostly reserved for car accidents and stuff on Via Boquete.
Okay.
And so they have to be on call for that. They're on call for that, for fires, because when the firemen go out, obligatory.
Ambulance has to go out.
The ambulance has to go out with them. So that one is kind of reserved for that. But they will do a favor once in a while when it's a huge emergency and nothing else is available.
Yeah.
The Social Security ambulance is available by the 911 sometimes, as long as the Social Security doesn't need it.
And I saw Joshua post something about like the night ambulance hours or something like that, and I'm not sure.
The municipal office has an ambulance. The problem is they only have a driver. So if you need a paramedic or a doctor to go down with a patient, they don't have one of those.
Interesting.
Sometimes they don't have oxygen on board and that kind of thing. And patients.
So it's a glorified car at this point.
It's a transportation vehicle. I've gone down in that ambulance with a patient before. We actually had to get oxygen from MENSA so that I could bring the patient down, because the patient needed oxygen to be able to go down. They weren't stable, so I had to go down with them. And that's the problem with the ambulance. Also, the driver, I believe, is not right in Boquete. So it would take a little bit to get the driver awake and get him to Boquete and get.
And again, I think this is when we talk about what we're trying to do. It's all of these things that you're mentioning. I think it's like all of the limitations, and you're talking about a driver's that here. Well, depending on where he lives, how long is it even going to take for him to get there? And then depending on where the emergency is. So I mean, you're easily, it could take up to an hour.
No,
I mean,
more.
Yeah, and I was going to say
about 2 hours. It took that particular patient 4 hours. 4 hours.
4 hours. Wow. Yeah.
And that particular patient had an asthma attack, and their oxygen saturation wasn't the best, so they couldn't breathe, and I couldn't send them down in a personal car without oxygen.
Yeah. Yeah, and so I think
So it took a while.
yeah, and I was gonna say, I think that like these are the realities that when we talk about and understanding, because I remember I had a situation with a veteran that went into a PTSD episode, and I ended up I was an acquaintance and ended up being on the phone with the crisis hotline in the U.S. and they're like, oh, we're gonna send you an ambulance, and I'm like,
No,
okay,
you're not.
and so like they have me on hold and all this stuff, and then it's like. Then they're like, "Oh, ma'am, we're so sorry, we can't get a hold of an ambulance." I'm like, "Yeah, I mean, it's the reality," and I
Yeah.
think that like having us try to be as self-sufficient as we can here is hopefully going to make a difference and save lives.
Yeah.
Because, I mean, yeah, this is sad.
I mean, it's a fact that's been going on for a long time, and that's why we get so many emergencies into the clinic, and we can stabilize them just
Yeah.
fine in the clinic, and usually they can go in a personal vehicle.
Yeah.
Now, there's other things that we can't, or they don't call us to go to, or we can't get to, like falls and things like that, where they're way off in the middle of nowhere, in the middle of the night. You know, we cannot normally get to those really dark, really closed spaces, but we do go around the immediate area. We have gone into Jaramillo Centro to go see a patient. We have gone up to up way into Volcancito and seen patients for emergencies. But yeah, when it comes to actually, if they need a hospital, then it's usually up to the family member to get them down to the hospital.
To get them, yeah. And I think this is something too, to where if we get this group together, having them also contact you and be able to specifically say exactly what they need from you, how they need for you to be prepared, and kind of be able to talk to some of these doctors and clinics.
Because
and stuff.
some of them can come right into the clinic.
Exactly,
Yeah.
exactly. And so I think that this is something too, like to have people that can work hand in hand with you and be
Yeah.
able to say, hey, Dr. Shannon, this is exactly what we're looking at. And then when they come in, you're
Yeah.
not guessing what's
Right,
going on.
right.
Because I think that happens in emergency too. I don't know anything outside of like watching like Grey's Anatomy or something like that. And so then if something happens to me and you call me and you're asking me, you know, what's going on, I wouldn't
Right.
necessarily be able to like explain, you know. So having this citizens that are trained to be able to explain and say, hey,
Certain issues.
yeah. And I think to be able to ask those, you know, certain questions is going to be interesting. I think one of the other things that we're looking at is kind of like, how are we going to get this dispatch to be able to specifically tell us where people are.
Right.
And so we're talking with some people like Disaster Dave that was he's has some training in some of the stuff, and he's like, hey, there's some programs and there's some apps and things that, you know, because that's
And
a big
sending a pin by WhatsApp sometimes will work.
yeah, so sending a pin by WhatsApp will work, you know, because I think that's a big problem that we have as well. It's kind of like, oh, well, you know, where are you? Oh, well, you know, where the old, you know,
Yeah.
tree used to be. Well, now it's the, you know, I mean,
But
it's,
if you weren't here 10 years ago, you have no idea
you
what
have
that...
no idea. And I
Yeah.
think that that becomes something as far as for, you know, some of this that it comes with creating an infrastructure for people to be able to reach these places
Right.
in a timely manner. So.
Overall, it sounds great, but yeah, like you said, it does help a lot, you know, especially if they're calling in saying, I think we need to bring this patient to you. What do you think? Should they go to the hospital or should they come to you? And, you know, most of the time, we're closest to be able to help stabilize. You do the initial stabilization, and then we are able to evaluate more in depth and then decide, does this patient need to go down to the
Absolutely.
hospital, that kind of thing.
Absolutely.
Because like you said, not everything needs to go straight to
No.
the hospital.
No.
And that's what a lot of people want. They want to go straight to the hospital, but a lot of stuff doesn't require it. And that's why it's a lot harder to get an ambulance, because so many people call an ambulance for things that
for something really simple. Yeah.
that doesn't really require the ambulance, and the paramedics have to go check out the patient, decide, okay, does it fall under the criteria of going to the hospital or not? And a lot of times it doesn't.
Absolutely. And I think this is where, you know, Fire Panama comes in with making sure that we're talking about how qualified these people are going to be
Yeah.
to handle this initial contact with a patient, because I think it's really important to talk about, hey, they're going to be certified, this is what it's going to look like, hey, these are the instructors, because I think we want people to feel confident when someone's coming from this core of first responders,
Right.
that there are really, because that can be kind of scary as well. You have someone coming in and you know that they're from a volunteer corps, you know, so this is why it becomes really important for people like you to be involved in what's going on, and we can kind of talk and explain and say, hey, these are the certifications. What do you think? Because that can be kind of scary for some people as well, and some of the big questions that people had when we had the initial meeting was liability. What is
that's
that?
a big one. That's a big one.
And what does that look like?
Yeah.
Because we're, especially from the U.S., you're so used to getting sued for everything and all of this stuff, and so I think that all of this stuff is stuff that we're looking at, and I'm learning myself because I'm just more of the representative from the foundation saying, hey, I think this is a really good idea, but I am definitely not
I
don't know anything. I think we were doing a interview the other day, and someone was saying, Priscilla, we're so glad you're not teaching the course. I'm like, I would be like, so hit the thingamabob.
Right.
So, but there are going to be qualified professionals, and these are international certifications that are also Mensa certified. So these are things that actually will come, and the idea is for these people to be prepared. We're not going to send someone out there kind of MacGyvering their way through crisis. So.
Right, exactly. You don't want a loose cannon out there. You don't want anybody that's not psychologically stable out there either.
Exactly.
So they assume everybody goes through some kind of a vetting process.
Yes. And so, even some of the first aid, CPR training things, like, these are all kind of vetting process for the team to kind of get to know people, interact with people, but
And also not everybody's going to be able to handle the physical effort that it requires to do CPR. If you've never done CPR on a person that requires it, then it's very strenuous. It's very strenuous.
I believe you. And I think too there are going to be people that can't handle the sight of blood or can't handle the sight of
broken bones. There's
and,
some nasty injuries that come in that even make me go, eee.
And I think too, especially with the fact that we have a lot of people out in the elements doing things like hiking, rafting, waterfalls. So the chances of people seeing broken bones and things like that,
and deep cuts,
exactly. So that's all part of what this looks like. And so if someone isn't prepared to handle that, then they're going to be needing the ambulance service as well because they passed out. So
that's all you need is two people that are down.
Exactly. And so I think these are all really important conversations to have with the people to understand what they're getting into and what they're going to be giving to their community.
And I would assume these volunteers are going to go in pairs.
So that is a good question. I will find out because, yes, that would be something to consider now that I am talking about.
Because you cannot work on a patient and also call 911.
Very true.
And
very true.
The family member is probably not going to be in the right frame of mind to call 911 and explain what's going on either. So usually you want to be in pairs.
And that makes sense. And I think most of the people that I've signed up so far are like a husband and wife, are people. So could be, but I will definitely get back with you because I think it's a really important question to find out.
Especially safety-wise, too.
Absolutely. I think safety-wise, liability-wise, everybody, I think having two people. Now, the idea is when the call comes into the call center, who's the closest to be able to go. And so these kits are going to be in people's cars, so they'll be able to. So the thing is that, like, if you're in Palmira and a call comes in for Palmira, then you'd be able to go. If you're far away, then don't answer. Things like that. So
the closest person should be answering.
Absolutely.
Yeah, I was working in a clinic once as the only doc there with no nurse, with no paramedic on duty with me, no nothing. I ended up saying, I can't do this anymore because you never know when an emergency is going to come in. And you can't both work on the patient, evaluate them, treat them, and at the same time...
do the logistical part of it all.
Set up an ambulance or whatever you might need. It's just too much of a legal liability and too much pressure on one person to have to take care of. If a heart attack comes in, if somebody comes in choking and stops breathing or whatever, you can't do everything at once.
Absolutely.
So...
Yeah, and so these are all things, and again, this is like the exploratory phase, we're looking to start this off, we're getting people having the conversation, getting people involved that can do the training. Like I said, having conversations with Rotary, who is looking into some sort of ambulance service.
Right.
So all of this stuff, again, is just starting this conversation within the community and saying, hey, like, this is a real problem, and like, maybe we should all work on it together, and what does that look like? And so,
because you do have a lot of people out there that were medics or paramedics
Absolutely.
or EMTs, and we have a lot of experience. I worked as an EMT. I've got that side of the experience, the pre-hospital, and then I got the hospital side of the experience.
yeah, and so it was really
you do
cool.
need people to work together to figure out what is the best.
Absolutely, and I think you mentioned something really cool, because in the first the first meeting that we had to kind of just talk about it, there was like 3 paramedics that had worked, you know, that had been their job, you know. So it's interesting. Like, a lot of them are excited because now this is something that they can actually be a part of in the community using their experience.
Right.
And so we're not starting from scratch.
Exactly.
Which is nice as well.
People that have that experience and that have desire to keep doing what they did in their previous life before they came here.
Absolutely. So yeah, I mean, this is all very interesting.
Yeah.
And again, I think the biggest thing is we have to think of things that are going to take care of ourselves as a community, and
Right.
you know, so you know, what this looks like going forward, you know, we'll probably talk in several weeks and say, hey, this is what, you know,
This
we've
is what's
learned.
going on now.
Yeah, this is what we've learned. This is what, you know, because I think all of this is kind of that, you know, you come in. Well, I've found that out in Panama in general. You'll come in with this great idea, or what you think it's a great idea, and once you start like kind of getting involved in the nuts and bolts, you're like, oh man, we need to tweak it a little bit. And so yeah, I mean, the conversation has been started, and again, as we go on and we're starting to meet new people that are getting on board with this, what this looks like even in a year, I think is going to be really exciting, and we may have some solutions to some of this stuff. So
Yeah, and it does take a little bit to work it out. I mean, it's not just you come in day one and you know everything that needs to be done. There's a lot of
Absolutely.
factors that you have to take in, especially in certain communities. Not all communities are the same.
absolutely.
Not all the issues are the same.
Absolutely. And I think, yeah, you're talking about, here we're talking about there could be language barriers, cultural barriers, physical barriers. So we're talking about, it's very hard. It's going to be interesting to see how we prepare a community for the needs of the community when the needs are very diverse.
Right.
So
It like I said, it depends on where you're living too. In David, it's not as much of a factor to get to a hospital really quick if you need one. Panama City obviously has
Absolutely.
really big hospitals, both private and public. You know, a big trauma center.
accessible roads for the most part as
Except
well.
for traffic.
Yeah, except for traffic, yeah.
You could use a flying car sometimes, but each community has its difficulties and its benefits, and this community just happens to have a lot of retirees in it. A lot of people that are older have more health problems and have more risks. And it goes without saying that it makes it a requirement that we have better emergency services.
Absolutely.
You know, not that young people don't require emergency services.
No, but I think exactly, and I think that like something like this is long overdue because of that. When we're talking about a higher community, you having people that are going to be going into, you know, respiratory arrest or heart attacks or things like that are going to happen just more frequently just because of the demographics. So
Exactly.
So having these conversations here, it's important. It's important, and I don't think it makes us selfish, or it makes us to kind of think and say, hey, I'm coming to Boquete and I'm going to invest in something that I would most likely use. Because at the end of the day, if a Panamanian or if anybody calls in, a visitor, a tourist calls into this hotline, they will be taken care of as well. So the idea is this is something that helps us all.
Right, and I know that the Panamanian community has been complaining a long time about the need for emergency services, more clinics open during the evenings for emergencies, better equipped ambulances, better equipped clinics. You know, we have a pretty good clinic. We're equipped for most emergencies. We can intubate. We've got an AED. We've got nebulizers for asthmatic emergencies. We have medications to give patients that have had heart attacks and we need to stabilize to be able to get them down to David. We can do sutures. We can do IVs.
Perfect. Wow, a lot.
So we do a lot, and we are available in the middle of the night. You know, we're not open 24 hours, but we're available 24 hours.
Makes sense.
So it's you know, we're one of the few clinics that can say that. And we are proud to say that. And we, you know, obviously love to have a pre-hospital, pre-clinic help before they get there or when they actually need it, because we feel helpless when they call in and either they can't bring the patient down or we can't get to them. Or they can't afford us to go out and do the house call.
Yeah.
Which, it's not an expensive thing, but if you're a local or if you're someone that's living on a strict budget, it might be an extra expense that you can't afford.
Absolutely. And so, and I think that the idea for this is not to replace anything that's being done. And I think it's really important to say that this is to be supplemental. This is to work alongside the clinics, alongside the ambulance. This is not,
you don't replace the
we
doctors.
do not replace the doctor. We are not here. And I think it's really important to say that as we build the confidence is letting people know the limitations and as this goes through talking about and saying, hey, these are the things that we can do and these are the things we cannot do.
Right. You're not going to be giving IVs.
We're not. Yeah, there's a lot of stuff that we're not.
You're not going to be paramedics and you're not going to be doctors.
Exactly.
You're going to be a volunteer
Absolutely.
This aid CPR type of service.
Absolutely. This is someone that's just going to be there to be able to assess, to be able to help, but this is not someone that is there to replace. And I think
help stop the bleeding.
Yes, absolutely. Someone that's going to be, but we are not saying in 8 months people are going to walk out of here surgeons and doctors.
Exactly.
I think I want people, because I think it's really important for people to understand those things.
Exactly. That you don't take 8 months and become a doctor.
Yeah, absolutely.
You can't diagnose a patient.
Absolutely.
You can say this patient is bleeding, this patient is having trouble breathing, this patient is this patient is that. But you can't say, they're having a heart attack, because you don't know.
Absolutely. And I think this is kind of where, the team will work closely with your team and things like that to kind of make sure.
The local,
absolutely,
the local,
exactly. But yes, we are not replacing. I say again, we are not replacing.
Yeah, it's not that you don't still have to go to the doctor. So in some cases, it's just a minor thing and you won't need to go to a clinic or a hospital.
Absolutely. Once, they would call and say, hey, it was just someone choking on an object. This is what I did. This is what happened. There are things where, it was just basic CPR.
Or whatever will say, okay, I think you need to get them an ambulance, or I think you need to get them to a clinic.
Absolutely.
Yeah.
So,
you guys don't make the decision.
Yeah, there's going to be things in place to make sure that, we're protecting from the liability as well.
Right.
So,
because legally you cannot diagnose.
Yeah,
legally you cannot say you don't have to go to the hospital or you don't have to.
Absolutely. Yeah. And being as far as, this is going to be a corps that is made of expats, we want to make sure, medicine is a protected field, so making sure that, this is not, crossing any boundaries or any lines when it comes to
you have to do within the guidelines that you're allowed to do.
Absolutely.
And that's where Fire Panama comes in, that's where the mayor comes in, that's where MITSA comes in.
Absolutely. So this is all going to be, and again, this is completely above board. So for those that are interested in coming out to the initial, first aid, CPR class, definitely we can reach out.
It's this coming Saturday.
It's Sunday. This coming Sunday. It's going to be at Tap Out.
Okay.
From 8:30 to 4.
Okay.
Refreshments are included.
Number of contact?
So I'm going to give my number because it makes it a whole lot easier.
Okay.
6635-0628 is going to be the WhatsApp number, or you can also email ACCBboquete@gmail. You can find us also on social media, on Facebook, on Instagram as well, and reach out.
I've seen the ads.
Yeah,
I've seen the ads out there, so you can reach out to one of those ads even.
Yes, for one of those ads, we're constantly checking all of that to make sure. But we're excited about being a part of the community and hopefully being a part of the solution. So
it sounds like an excellent initiative to me. I hope it all goes well.
Yes.
I would love to go and join in some of those classes just to see what's going on.
Yeah, and I think that'd be super cool.
And I think Leo was going to probably let me get in there and see.
Oh, perfect. And I think that's really good as well, because I think you're going to give a local perspective, because of course Leo and Fire Panama's coming in from Panama City, but you're the one that has the pulse on what's happening right here.
I still have to talk to you, Leo. I'm sorry. I missed his call yesterday. I was with a patient.
So he would have loved, him and Yaakov would have loved to be here, but because
I understand the Sabbath.
It's Sabbath,
Yeah.
and so they called me and they're like, Priscilla, you think you can do it? And I was like, well, I think so. I think I can talk about what's going on. I've been kind of in all the meetings and stuff.
Yeah, I mean, I wish I could have even had them on the phone, but I don't think they can even do that.
No, they can't do
no
any-
electronics, no cars, no nothing. It's
no.
all shut down on Saturdays.
I know. It's their day of rest.
Yeah,
So,
no, that's fine.
I get it.
But I can do it through you. I mean, you can talk
yeah,
and get
for sure.
the
Yeah,
info
so for
and-
sure. And I mean, I think, going forward, if we do another interview,
Yeah.
like, I mean, we can have something pre-recorded from them as well.
Definitely, yeah, definitely.
Because I want the community to get to know who these people are, and
Yeah.
and the fact of how much they care about our community and wanting to be a part of the community is really cool. So
Yeah, and does Leo speak English?
a little bit, yes, yeah.
Okay, I think I just went over time.
Oop.
Anyways, I was just asking because of the video. He
Yeah.
can watch the video of the program that's on. We're recording.
Oh, okay, perfect.
Yeah. Hi.
Hi.
It's YouTube. Okay, so we're out of time for today. I'll definitely have you back on
Awesome.
during the time of the course. And again, I'd like to thank you for coming on the show,
Hey,
Priscilla.
no problem.
From the CCB, Boquete.
yeah.
I'd like to thank William Tour, Dr. William Tour from Florida for being on the program. And I would like to thank Zuleika again for being our engineer for the show. And down in David, Veronica, and of course, Roger too. So everybody have a great weekend. We'll see you next weekend. Bye-bye for now.